introduce. All right, everyone, quiet. Okay. Quiet. Quiet, quiet, quiet. Okay. So now I'm going to introduce Dr. Baiju Shah, who comes to us from the University of Toronto. And Dr. Shah has extensive training in diabetes, both clinical as well as a PhD in clinical epidemiology. And he is with the ISIS group. He heads the diabetes-related portion of this group. And he's done many groundbreaking studies in diabetes epidemiology, gestational diabetes. So a lot of any methodology questions you have which could be relevant across health outcomes, he's the person to answer them. So without further ado.
Great. Thank you very much. So it's a great honor and privilege to be here today to speak to you. And I'm going to speak this afternoon sort of on a methodological topic in terms of how do we do work understanding ethnicity and visible minority populations using healthcare administrative data. And I work at ISIS, as Kaberi mentioned, and as many of you may have heard the story of our name. So it was originally the Institute for Clinical Evaluative Sciences, which was always abbreviated as ISIS, because that's just easier to say. But recently, there's been a concern with that name because it gets mixed up with a terrorist organization. So we went through this whole kind of rebranding process. And there was a lot of money spent and a lot of consultations. And there was people who were very against any kind of name change because we were established as a brand, and others who said, well, we need to change things. So the final decision was our new name is ICES. So it no longer stands for anything. So we're meant to be like BMW. So when we submit our papers, we're supposed to say we are from ICES, and the journal is just supposed to say, oh, okay. And and if they say, well, what does that stand for? We're supposed to go into this big long description of why it doesn't. I still put Institute for Clinical Evaluative Sciences because I can't be bothered. But in order to help promulgate this new name, they also changed our logo. So this is our old logo. And they spent, again, all the millions of dollars to rebrand and print everything new with our new, with our new logo. And so apparently the slash is meant to make it clear that the name is now ICES instead of ISIS. What it has instead done is everybody now thinks the name is IC/ES, which it isn't. And so it's just led to further confusion. So I still say ISIS because it's going to take me about 5 or 10 years to get used to the new name. But you will soon learn about IC/ES. So what I wanted to talk about today is to go through some of the methods that we have used using the population level healthcare administrative data that we hold at ISIS. See, I'm still going to say it all the time. To be able to identify and therefore study visible minority and immigrant populations. And I'm going to go through sort of the methods part of it and then just give examples of kind of studies that we've done in using those different methods. Most of the examples I'm going to give you are diabetes studies, because of course that's what I do, and it's the most important disease. But there will be some examples from other fields as well. And obviously I want this to be kind of interactive and informal. So if you have questions along the way or comments, just let me know. So, health services research, as we all know, as we are all in this business, is really to understand how people use healthcare services and what are the barriers to people's use of healthcare services. And there's this paper that was published a few years ago that was sort of meant to be a kind of an overview of what are the social determinants of health in Canada. And many of these are obvious, and many of these are things we think about. Many of them are things that we can't actually measure using administrative data or population level health research. But obviously down here we do get into race and ethnicity and Aboriginal status as important predictors and important determinants of people's health. So these are things that we want to be able to measure and analyze. And so therefore we've been working hard to try and develop ways of doing this. But I guess one of the challenges we face in analyzing ethnicity is that Canada doesn't really have a generally accepted categorization of ethnicity that people can use, unlike, for example, in the United States, where it's very clear. There's white, there's black, there's Hispanic, and now occasionally they'll throw in Asian and Pacific Islander, but that's it, right? Everybody it has those 5 categories. People are familiar with those 5 categories. People are used to being asked which of those categories they fit into. And so it's kind of part of the culture in the United States to know what race, ethnicity you are based on those categorizations. And I was saying this morning, I mean, the example I always draw is Barack Obama, right? Barack Obama had a African-American father, or not even an African father from Kenya, and his mother was European, and he was born probably in Hawaii, although don't tell that to Donald Trump. But if he was filling out a form in the United States, he would say that he was black because that's what he was, and that's how he identified himself, and that's kind of where he fit in that scheme, even though arguably he was half white. In Canada, I'm not sure how he would have, if he was a Canadian, how he would have answered that question. What is your ethnic background? He probably would have indicated both, because that's something that we can do here that isn't really done in the United States. And it's a bit of a challenge because we don't, he probably would never have even been asked the question. And certainly in many of our data sources, we don't have information on race, ethnicity. So certainly in healthcare, that data usually isn't available. And in other sectors too, it's just not there, whereas it is commonly there in American data sources, in hospitalization databases and in school registry databases and so on. So we don't have the same access to the variable in Canadian data sources that you would in the US. So this is why we have to come up with these other ways to try and get at what people's ethnicity is. So one of the methods that we've used is to use surname-based proxies. And there's actually quite a history of using surnames to be able to identify people from different ethnic backgrounds. So the first example was actually in the US. They took the census in 1950 and came out with a list of Spanish surnames, as I called it at the time. And that original list has been updated with every 10 years of the US Census, and it's being used actually quite extensively to identify Hispanic populations for research in the US, because of these are sort of Spanish surnames that are unique to the Hispanic population in the US. There have been many other cases where these kinds of surname approaches have been used to identify ethnic populations. Another classic example is some research looking into Korean populations, because in Korea there's only 5 surnames, and so if you have one of those surnames, that identifies you as Korean, and that's been used for health researchers' purposes. In Canada, our focus has really been on the Chinese and the South Asian communities, because those are our 2 largest visible minority groups by far. And for Chinese surnames, there has been some research done in the past and some surnames algorithms developed. And it's a little simpler because there's sort of a limited number of Chinese names, like in Chinese, that then get anglicized in various ways. So you can have multiple different anglicizations of the same original name, but it's still a finite number. And so you end up with a list of Chinese surnames. And there's been several of these lists that have been developed actually in Canada in different places and at different times over the years, and have been validated against things like place of birth, to demonstrate validity to identify Chinese populations. There was actually one interesting study that they actually used phonology rules. So what does the name sound like to identify who was Chinese, and they went through the Waterloo phone book to find everybody who had those names that met the phonological definition of a Chinese name, and just phoned them up and said, "Are you Chinese or not?" And came out, reasonable sensitivity and reasonable positive predictive value, and so that's been used in the past. And so creating a sort of a surnames algorithm for Chinese names in Canada was relatively straightforward because it's been done before many times. South Asian names were a little more difficult because, first of all, there's a lot more South Asian names, and different parts of India and Pakistan and Bangladesh have different ethnic and different religious and different language backgrounds, and therefore a huge variety of different surnames. There have been some lists in the UK where they've tried to use this methodology to get surnames to identify South Asian populations, and in fact using first names and surnames together to identify South Asian populations. The challenge with these has been that while they've been really good and quite sensitive where they've been developed, even when you try and sort of extrapolate that same list nationally within the UK, the sensitivity dropped down quite low. And so you can imagine going to an entirely different country and importing those names here would be even worse. And I think this is a reflection of the fact that South Asian immigration into the United Kingdom has been somewhat, ghettoized is maybe not the right word, but Gujaratis go to this part of the country and Bangladeshis go to this part of the country and Bengalis go to this part of the country. So you get, very good specificity in leads to identify Gujaratis because of their surnames, but that's not going to help you to identify South Asians more broadly elsewhere in the country. There was one attempt at developing a South Asian surnames list in Canada that was done using mortality data. So the death data included information on place of birth. So they identified people who were born in India or born in places that had a lot of migration of people of Indian origin, like Kenya or Uganda, and used that to identify surnames. And they actually got quite a good sensitivity in this small study that was done in Hamilton to be able to find South Asians. But that wasn't, I think, it wasn't an exhaustive list and it wasn't broad, and we wanted something a little bit bigger. So we went through this effort to try and create Canadian surnames lists for identification of Chinese and South Asian populations. So for the Chinese ones, we just used the existing lists with a few minor modifications. For the South Asian one, we actually got on Amazon, they had this great big book. It was called the Encyclopedia of South Asian Surnames, which was derived from Indian census data, and it was just page after page after page of surnames. And so we went through that, and with a consensus panel, went through a process to try and exclude names that we felt weren't specific, because we wanted names that were going to be clearly identifying South Asian people and not contaminating with other ethnic groups mixed in. So we removed names that were not specific to South Asian populations and using a consensus process. And so then we applied that surnames list to our population health data. So this is how the population health data comes in from the Ministry of Health in Ontario. So obviously this is just made up, but we have everybody's health card number here and we have their names. And then we would apply our surnames algorithm to it and encrypt their health card number. So this is the encrypted health card number that's used across all of the databases, so you can track an individual across data sources. And then we would just assign them to the correct population based on what their surname was. Now, obviously, there are other ethnicities where we didn't have a surnames list for, and so they would just end up in the general population. So our general population isn't really a European population, it's an everybody else population. But based on census data and so on, we estimate that about sort of 85 to 90% of what we call general population are people of European background. And then we would apply this algorithm to the rest of the encrypted and administrative data to be able to do research. So in the end, we ended up with about 500,000 South Asian surnames, about 800,000 Chinese surnames, and then everybody else. Now, this is obviously not reflective of the entire population of South Asians and Chinese people in Ontario. It's much larger than that. And that is, again, by design, we deliberately made it a specific list, not a sensitive list. So we wanted high positive predictive value and high specificity. So these were the most common South Asian surnames from our list, and these were the most common Chinese surnames from the list. But you'll notice, for example, a very common Chinese surname like Lee, L-E-E, was not on the list, because that could also be English. So we didn't have that on our list deliberately, and so that name isn't on there. And so somebody with the surname Lee, who is Chinese, would be misclassified as a member of the general population, but we wanted it to be specific. So we did actually test the sensitivity and specificity using our linked data to the Canadian Community Health Survey, where people can self-report their ethnicity. And we found very high specificity, which is what we were aiming for, pretty good positive predictive value, which is what we were aiming for, but sensitivity by design was not great. So we lost about 20% of the Chinese population and about 50% of the South Asian population. And again, that was deliberate. A lot of, for example, Muslim South Asian names could also be names of Muslims from other parts of the world, from Iran or the Middle East. So we left those names off, but that's a large part of the South Asian community in Ontario. So we lost about half, and my surname, for example, isn't on the list because that could be Iranian. But Dasgupta, I think, is on our list, so yes. Yeah, exactly. Yes. So we have then taken this file, which we now can identify everybody in Ontario as either Chinese, South Asian, or general population, and we can use that in health research. So this is a paper that we did a few years ago where we took everybody newly diagnosed with diabetes over a 7-year period and divided into ethnic groups by the surname. And we followed them forward for cardiovascular complications and for mortality over the next few years. And we found that the rate of cardiovascular disease after diabetes diagnosis was actually similar for South Asians as it was for our general population, mostly European population, but was actually half that rate amongst Chinese people. So once you develop diabetes, your risk of cardiovascular disease is only half that of a person from the general population if you're Chinese. And similarly, mortality for both minority groups was sort of 40 to 50% lower than it was for the general population. So this was just an example of how we were able to use these data and apply it to a real question about phenotype after diabetes diagnosis. And it's been used outside of diabetes too. This is a study that Ophira Ginsberg did looking at invasive breast cancer in 41,000 women who were diagnosed over a period of time. And her question was about staging as a sort of a window into screening behaviors. And so she wanted to look at the odds of being diagnosed with stage 1 disease versus later stage disease, with the reference population being the general population. And so South Asians were actually less likely to be diagnosed with early stage disease, whereas Chinese women were more likely to be diagnosed with early stage disease. So that can help, therefore, inform decision-making around cancer screening behavior, particularly for South Asian women in Ontario.
Mm-hmm. Have you compared those who have names that, because it's half of the population,
Yeah.
Right? Have you compared them to the people who are really authentic?
No, we haven't done that. So that's a good point. We actually just left those names off. So yeah, we dumped them. So we haven't gone back to actually pull them out again, which is a good thought. We should actually maybe do that and pull out the ones that we deleted and take a look, because we haven't done that. Yeah.
I guess the other question, since we're starting questions,
Yeah, of course.
But would be, so what we did in the past with Quebec data, because we had birth registries, so we had for the moms and dads country of birth and language, and then we kind of did an and/or statement. Did you do that with country of birth? Because I wonder if you'd bring in, so you could have the surname, and then, or if they're born in particular countries, maybe.
Yeah, so I'm going to come to our immigration data in a second. So there's been some research where we've merged the two approaches, but for the most part, we've been using one or the other because it's slightly different populations, right? The one is immigrants, and the other, it could include Canadian-born people with the same surname. And obviously, the surname approach is like, it's only going to work, in 30 or 40 years, it probably isn't going to work so well, right? Because people are going to have got surnames that don't necessarily reflect their ethnic background, or only reflect only half their ethnic background, or whatever. So it's probably not going to be a method that we can use for the long term. I think probably what I would love to be able to do is to do like what the Americans have done with the census, and actually go to the Canadian census data, where people have self-reported their ethnicity and see what surnames have a high likelihood ratio of being a Chinese surname or a South Asian surname, and there even maybe we could start looking at other ethnic groups as well, and see if we could do that. My understanding has always been that when you fill out your census form, they collect your name and your phone number only for the purpose of getting you to fill out the damn form, and then once you've done it, they take that off, and they can't do that anymore. But I've seen some studies out of StatsCan that suggest otherwise, so I don't know whether it may be possible. So, yeah, but that's only a few thousand people, right? Not all 12 million people or 30 million people across Canada, right? So it would be better to.
Can I clarify? Are you saying they don't collect ethnicity data in the census data?
They don't collect the names. So it would be nice to be able to say that everybody who, like Shah could be a Persian surname, but if it turns out that 90% of the people whose surname is Shah in Canada self-reported as South Asian on the census, then we could put it on the list after all, right? So, but apparently we can't do that, but maybe we can.
But it's interesting, a comment you made earlier about the American system. It's there's a high probability it leads to misclassification. Like the good thing is everybody's classified, but the bad thing is
Yes.
a lot are misclassified.
Yes.
So
But what's misclassified, right? I mean, it's if that's how they self-identify themselves,
but they're only given certain categories.
right?
So
Yeah.
you have to
choose.
sort of
Yeah.
choose one.
Yeah. Fair enough. Yeah. Yeah. But I mean, maybe that's a more even a sort of bigger philosophical question with studying ethnicity. Like, what is somebody's ethnicity? Is self-identification the right way? It could be. There's no genetic marker. There's no like. What is the gold standard? Right? We don't know. So.
So the algorithm could be applied here in Quebec?
Yeah, absolutely. I mean, but again, whether it's going to be generalizable to the South Asian and Chinese population that immigrated to Quebec, who knows? It probably is reasonable. It's probably not going to be that far off, but it could be done. Yeah. So another method we've used is to use these neighborhood-based ecological proxies, and this is something we do all the time. Could use census information to get sort of the average of a characteristic across a region, and then attribute it to everybody who lives in that region and divide it into quantiles. And like this is our classic thing with income quintiles, for example, is to use this approach. It depends really on the geography, though, and this is where the geography becomes really important because there are different geographic levels that are available in healthcare databases, and so some of it might be the health region, what we used to call local health integration networks in Ontario, but which Doug Ford has just cancelled, so I don't know what we're going to have now. Or it could be at the level of the municipality. But really the most precise geographic measure is the postal code, which is often on healthcare data, right? Even when you come into the hospital, you get your postal code is recorded in your record. And in an urban area, it actually works quite well because a postal code is going to be one block, one side of the street, and your neighbors across the road have a different postal code, and the neighbors on the next block have a different postal code. So you can get very precise geography out of a postal code in an urban area. But in a rural area, it's not useful at all. So I grew up in a town of about 5,000 people in eastern Ontario, and the entire town and surrounding area had the same postal code. So it's not useful in that sense to really pinpoint exactly where I lived because it could have been anywhere in this large area. But the advantage of that small area, at least, is that can be then stacked up and rolled into other larger geographic units. So, for example, there's the forward sortation area, which is often used for health research. It's just sort of the truncated first 3 characters of the postal code. The problem with the FSA is it's designed for mail delivery. It's not designed for population or healthcare delivery or anything. So, this is one FSA to represent the Legislative Assembly of Ontario, or another FSA to represent the TD Bank Tower. But those both have populations of 0, right? So they're not meant to be representative of populations. They're just meant to make it convenient to deliver the mail. So it's not, I mean, it's accessible and available, but it's not necessarily useful. Another geographic thing that can be used is the census subdivision, which is kind of, the municipality. But these can also be quite variable. So, I mean, obviously, Toronto is one census subdivision. So is the township of Chatsworth. So, how do you necessarily compare the geographies when you're looking at these two very different areas? Or this is the city of Kawartha Lakes, which used to be a whole county and then just got amalgamated into one enormous city. It doesn't have a big population, but it's huge in geographic area. So these are difficult to really work with. What's more useful from the census is that we come down to the level of the census tract, which are these, these are areas that are designed by Statistics Canada to be stable populations, and each census tract is meant to have approximately the same population and is meant to stay relatively stable in size from census to census. So these start to become a little more useful for measuring health data and so on. The challenge is they only tract urban areas, so rural areas don't get tracted, so you don't have census tracts in rural areas. And then if you get even smaller into the micro areas, you get into these dissemination areas. So each of these black boxes represents a dissemination area, which in the old days when the census was done by paper and pencil, this was like one StatsCan employee would be responsible for delivering the census papers to everybody living in one dissemination area and collecting them all and harassing them if they didn't hand it in and so on. So it was meant to be a very small, easy to manage area. DAs are good because they exist everywhere, even in rural areas. Even in my small town, we had 4 DAs. Like, it was all very manageable, and they're all very similar in size. So the DA is good, and in a city, you know, you can get the kind of through the postal code, you can figure out what DA somebody's in, but it doesn't work so well in urban areas, in rural areas. But I picked this particular map on purpose because even the DA can be still quite heterogeneous. So I don't know if people don't know Toronto geography at all. This is down here is the U of T, over here is the Royal Ontario Museum, and this is a part of town called the Annex, which was the original sort of upper class where the rich of Toronto in the 1800s used to live, where it was up here in the Annex. And still to this day, there are these enormous, so like this Admiral Street here, you quite literally have Margaret Atwood's mansion is on Admiral Street, and next door to her is a frat house for U of T with students housing. So even in one DA, side by side, you can have, you know, these enormous socioeconomic disparities sitting next to each other. So even you know, we try to get as heterogeneous or homogeneous as possible in these small areas, but there's still no guarantees that everything is going to be homogeneous. So, you know, as I said, like ideally smaller regions are more homogeneous, but so therefore you're not having such an error introduced by using an ecological proxy, but then getting data for those small areas can be challenging, and the postal code translation doesn't always work. There have been cases, though, where we've used this. So this is the Ontario Marginalization Index, which is a DA-based measure of marginalization defined broadly, and it's sort of covered into 4 different categories: residential instability, material deprivation, dependency, and ethnic concentration. And so for each of these factors, each DA is divided into quintiles across Ontario, and then that can be used to identify, particularly this one, to identify regions with high, DAs with high levels of immigration or high levels of people self-reporting as visible minorities, and we can use those to identify those neighborhoods, again, only in urban areas where the postal code is going to be useful, to identify patients who would fit into that category to study the Prehealth research. So for example, this is a study, now this is a McGill study using Toronto hospital data in Ontario. So Kabir, do you want to enlighten us as to how that happened? Because I still haven't quite figured that out. Yes.
Well, we had a very enterprising grad student who was from Toronto and who had type 1 diabetes. We had very good relationships with the hospital system, and we were able to access the data.
Okay, so good. So as Kabir could tell you, they looked at the glucose levels of women with gestational diabetes, the screening test for gestational diabetes, the glucose challenge test, and divided up the women based on the ethnic concentration and the material deprivation scores on the Ontario Marginalization Index. And they compared the glucose challenge test results between the most marginalized women. So these were women in the highest quintile for both ethnic concentration and material deprivation with everybody else. And they did find a sort of, higher glucose levels in those most deprived women compared to everybody else. And there's a lot of other analyses too, but I just summarized sort of that main headline on the slide. But so this is an example of where we can use those geographic proxies for ethnicity to try and to tease out differences in healthcare. The challenge, though, is for ethnicity, for the most part, it's difficult to really average ethnicity because there are going to be some even DAs or small geographic areas that have very high concentrations of South Asian people in Brampton, or high concentrations of Chinese people in Richmond Hill, or high concentrations of Filipino people in Wilson Heights. But those are few and far between, and even if you add them all up, you're only getting a very tiny portion of that actual population, so it's not representative. So it isn't really useful to use that sort of averaging method to find these populations. There is, however, one exception where we can do that, and that is with First Nations populations. So if we look at communities, census subdivisions, or DAs that are on these First Nations reserves, the overwhelming majority of the population living there, of course, are First Nations, and they are you know, a very significant proportion of the total First Nations population in Ontario, and are, you know, are obviously by definition all of the unreserved First Nations population in Ontario. So it is a useful way of identifying First Nations people to do health research. And you know, these are these kind of, many of them are these isolated communities. Some of them don't even have road access. They're only accessible through fly-in. And so we can identify these First Nations communities either based on postal code or based on the municipality address. Postal codes works reasonably well, but sometimes they will, again, in these large rural areas, the small First Nations community will share a postal code with the larger non-First Nations town down the highway. And so it doesn't always work, but where possible, we can use this. And so actually my very first study when I was a PGY 1 or 2 was looking at this question to look at ischemic heart disease rates amongst First Nations people in Ontario. And so we compared the hospitalizations in the First Nations with the general population of Ontario, and then also looking specifically at Northern Ontario general population residents, just to take into account differences in geographic access to care and so on. And this is good data, obviously ancient data now, but showing sort of decline in heart disease over time in the general population, but this big upswing in heart disease in the First Nations population. So it is certainly possible to use the geography as a proxy to identify First Nations people. There are other ways, and I'll come to that a little bit later on. So then the final sort of big category of being able to identify visible minority and ethnic populations that we've used is to find other linkable data. So other data that has ethnic identifiers on it, link it to the health admin data, and that allows us to therefore figure out what people's ethnicity are. So one big one that's commonly used is the Canadian Community Health Survey, which is this telephone survey conducted by StatsCan on a sort of every 1 or 2 year basis. And it's a nationally representative population-based sample with weightings to account for the sampling strategy. And each cycle of a CCHS has a bunch of core content on it, so that, you know, and that includes various important social determinants of health, including ethnicity, language, and other sort of immigration and other markers of these populations. And when the CCHS is administered, in Ontario at least, one of the questions also is to get the participant's health card number so that they can then be linked with the healthcare administrative data and followed longitudinally over time. So we've used this, for example, to study diabetes prevalence. So this was the first study I did looking at diabetes prevalence in different ethnic groups, where we took 20,000 respondents to the CCHS over 2 cycles and looked at their self-reported ethnicity in the CCHS and then linked them to the administrative data to determine what was their prevalence of diabetes. And so we found that the South Asian and Black populations had the highest prevalence of diabetes. Other populations, I mean, it was wide confidence intervals, obviously, because there were small numbers, but they had sort of comparable levels to the white population in Ontario. So this is a useful method because it's there. The challenge, again, and this ties back to what I was saying at the beginning about how we don't always think about ethnicity in Canada. People don't necessarily know what their ethnicity is. And I was saying this morning, there were cases in the CCHS of people who, you know, they said they were born in India. Their first language they reported was Punjabi, but their ethnicity was like East Asian or Japanese or something. So it's you know, people don't know how to answer the question in Canada. That's where we struggle. So again, what's the gold standard? I don't know. But it does become challenging.
What did you use to link the 2 databases? What was the link based on?
So when, in Ontario at least, when you complete the CCHS, you give your health card number. Oh. So we were able to link directly to the administrative data. So other ways of identifying people are to actually collect primary data on minority or immigrant populations. So chart reviews, clinic registries. If you have a clinic registry that happens to have ethnic identifiers in it, you can use that. Survey data, many surveys will have these questions, even though we're not used to that in Canada. It can happen, and so you can link that to the healthcare administrative data or other registries, and that's really where we've had the most success recently, is with registry data that includes, that has ethnic identifiers in it. So we have got this big database of immigration. So we have everybody who immigrated to Ontario between 1985 and 2000 in a database, and we've actually just recently updated that now to go all the way up to 2017, so it's much more up to date. But it comes from the federal government, and it has information on everybody who immigrated to Canada or to Ontario, and it includes information on what country they came from, what country they were born in, what category of immigration they came in under, so refugees or economic immigrants or family reunification or whatever. Information on their educational background, English and French language proficiency, various other important determinants of health that we can use. No health card numbers, because it's not a healthcare database, it's a federal database, but we were able to link most of them, either deterministically using the first name, last name, date of birth, or probabilistically where it didn't work, and only a small portion ended up being unlinked. And then we can use that to look at healthcare data. So this is something that Jack Tu, the late Jack Tu, did quite recently, where he looked at people's place of birth, categorized it into sort of different regions of the world, and this is cardiovascular disease events rates. So, and then each country, sort of the top 20 or 30 countries of sources of immigration into Ontario are listed, and you can see the sort of wide variation in cardiovascular disease rates between different parts of the world, with the big picture being that, you know, people from European, Western areas have relatively low rates. East Asia is even lower, but everywhere else has higher rates of cardiovascular disease, and with South Asians winning out at the top. And then long-term residence is sort of everybody else who isn't in the immigration database. So that includes immigrants who came before 1985, so my parents. It includes visible minority people who are born here, so me. Fortunately, none of us have had cardiovascular events, but we would be in the denominator there. And then it includes also people who sort of second, third generation immigrants would be all in that long-term residence category. So another great place where we've used these, and it's proven to be very powerful, is to study Indigenous populations. So our first foray into Indigenous work at ISIS was with the Métis and the Métis Nation of Ontario. So the Métis are sort of another important Aboriginal group in Canada that ancestrally traces their roots back to mixture of the French Canadian settlers and the First Nations parents who were and then sort of the progeny that have been carried forward. And they are a distinctly recognized Indigenous group in Canada. And the Métis Nation of Ontario partnered with us to give us their registry of all of the Métis members of the Métis Nation of Ontario, their citizenship registry, and we partnered with them to sort of deterministically and probabilistically link that with the health card database, and even, you know, great success rate with linkage. And then we've been able to work with the AMNO to study different diseases, including diabetes, in the Métis population. And this was some of the first sort of research in the population level in Métis in Canada. So we published this one looking at diabetes prevalence rates, so comparing the Métis with the general population across different ages, and this is males and females. And, you know, across the board, the Métis had a higher prevalence of diabetes at all age groups than the general population. So that was a really great example of how we were able to work with the Indigenous communities to do health research. And then more recently now, we've been working with First Nations population in Ontario. And this has really been a major, like this has been a huge strategic focus for ISIS and a priority and over the last many, many years. And we've got now the Indian Registry, which is a listing basically of everybody who are eligible First Nations people as defined by the Indian Act. And it includes a lot of information about their band affiliation, whether they live on or off reserve. And that data sits with the Federal Indian Affairs Ministry, but it's the OCAP principles, the ownership, control, access, and, oh, I'm embarrassed now, what's the P? Huh? No, it's ownership, control, access, and I'm embarrassed. I forget what the P is. But these are the principles under which Aboriginal data are held. And so the federal government recognizes that the ownership of those data actually resides with the communities, the First Nations and Indigenous communities in Ontario. And so we've worked between the three parties to bring the data into ISIS, the registry, and link it with the health card under First Nations data governance, and where the stumbling block in the past was always kind of ownership of the data, because once it's in ISIS, it's kind of within our building. But we've worked out how to maintain the sort of the ownership of the information, even if the data is held. So the data is held within ISIS, but it's still owned by the Chiefs of Ontario and owned by the First Nations communities. Yeah. Possession, thank you. Yes, P. Yeah, so P. That's the most important one. Possession, that's what we're talking about, yes. So P was the hang-up. And this is really, I think, a credit to David Henry, who was our former CEO, who really was pushing hard on this. He had spent most of his career in Australia, where they're dealing with very similar issues with the Indigenous population in Australia. And so he worked very hard to get this up and running. And now we have a strong Indigenous health portfolio and program that's running. I'm going to show you some cancer data. So they've partnered, there was a partnership, therefore, between the Chiefs of Ontario, Cancer Care Ontario, and ISIS to create this report on cancer in First Nations populations in Ontario. And this is just kind of the table, the first big picture from the report, which looked at the prevalence in women and men of the most common cancers, comparing First Nations with everybody else, and higher rates of lung cancer, likely due to increased smoking, but lower rates of things like breast or leukemia. So there are differences in the cancer burden. This goes on into a whole report that then goes into each separate cancer and looks at staging and prognosis and treatment. And it's a very detailed report that was just published last year. Sorry. We are doing something similar right now with diabetes. We hope to have it published both in a report form and in the CMAJ in the late summer or early fall, so keep an eye out for that. But we're looking at the impact of diabetes on Indigenous First Nations communities, both in terms of prevalence and complications and treatment and risk factor control and so on. So that's something that is coming. Keep an eye out for that. Yeah. So, I mean, again, I guess in theory that could be done. It would require, therefore, working with both groups together to allow that to be done. I'm not sure whether or not that would happen, but we could try that, yeah. But yeah, I mean, certainly, it would have been nice to have had another bar here, right, for the First Nations population, because you to see if the Métis are kind of halfway in between, which is, genetically what you might suspect, so, yeah. So that's one of the challenges is, for the most part it is. What we're lacking is in many of the remote northern First Nations communities, they'll have like a community nurse who sees patients on the reserve, and that they don't bill anywhere, so we don't have any availability of that data. The other specific challenge is a lot of the tertiary care in northwestern Ontario goes to Winnipeg. So we don't see that either, because they're much closer to Winnipeg than they are to Thunder Bay. So we lose that. But physician visits will capture dialysis, unless they're going to visit to Winnipeg, will capture drug claims, even though often they will be eligible for federally funded drugs. The Ontario drug program is still the first funder. So we'll see their Ontario drug claims data, and only if it's a drug that, for example, isn't covered in Ontario would they go to the federal.
Like, for example, we have people here from the north who come to the Glen for
yes.
You can link it.
Yeah. Oh, yeah. Absolutely. Yeah. Anything that happens within Ontario's borders, we can measure. It's only if they leave the province. There isn't. I think there is a tiny bit of bleed over into Quebec, but mostly it's towards Winnipeg on the northwest side. So that was it. I just wanted to sort of to summarize. So, you know, we've used a number of different methods to allow us to get administrative data to identify ethnic and immigrant populations, either using these proxy methods or to use linkage with other data sources that already have existing ethnic identifiers in them. And that has allowed us to really study how ethnicity and immigration can influence healthcare delivery in diabetes and in many other areas. But I think, you know, many of the principles that we've used here and many of the methods are nothing is unique to Ontario. Many of these are federal or across the board. So I think these are things that could be done here or elsewhere in Canada. And many of them have been done elsewhere. I mean, the surnames method, for example, has been used a lot in British Columbia and Alberta, and so it can be used in a lot of different places. So I welcome your questions and your thoughts on how this could be used here.
Excellent talk. So we have some time for questions. I'm sure you have some good ones. I'd just like to say this is a really
It's a really good example of an external speaker bringing us some methodology as well as experiences from other jurisdictions and provinces. So thank you for that. That's what we want from our speakers.
Hi. Really good talk. I was wondering, have you been able to compare, like going back to your surname list research, were you able to compare those results with other studies that used more traditional or self-reported ethnicity? Were those results consistent with what others have found?
Yeah, for sure. So I mean, it's. Oh, sorry. Yeah. So just in terms of comparing our surnames-based method with other methodologies to look at South Asian and Chinese populations. So the results that we've had here are consistent with what's been seen in other provinces, for example. Now some of them have also used surnames methods, but they've used different lists, like their own local lists, or some of them have applied the British lists where they can. And so we do see actually very similar results. Those diabetes mortality and macrovascular disease complications rates were almost identical in British Columbia as to what we found in Ontario. Yeah, I think we do have some suggestion that this is, generalizable. Yes.
If you think about something like an outcome where we think Black people do worse or First Nations do worse, but I was just thinking how there may be an underlying genetic reason, but then some of it might be healthcare access or other things.
Yep.
So I was thinking maybe if you're missing race ethnicity, but if you try to account for access to tertiary care or use one of the indices of marginalization or with the deprivation, right? So given that you will never, almost never be able to get at genetic differences with administrative data, should we just try to do a really good job with things like marginalization index and the disparity?
For sure. I mean, I think that's a great point, and that's actually maybe more actionable in a way. Like, if you've got a marginalized population, it kind of doesn't matter what ethnicity they are. If they're marginalized, they're having impaired, they've got access problems, they've got barriers to care, so that should be dealt with. I think if you want to start to get into sort of more the kind of physiological differences between different ethnic groups, then you need to be able to get better ways of identifying who's actually in that group or not. But I agree from a health services perspective, maybe marginalization is more important, and it doesn't matter why they're marginalized. But oh, sorry. Yeah.
I don't know if this is working. That was a great talk. Thank you very much. So actually, it's kind of followed up to the last question. It's, to me, I think ethnicity is a very important thing to study. It's always concerning that I suspect most people interpret studies of ethnicity as implying it's a proxy for genetics.
Mm-hmm.
And that question, I think, very much was kind of suggests that.
Mm-hmm.
I'm not so sure it's a strong proxy for genetics. or that it should be interpreted that way, how do you teach your audience or your people, your readership, to interpret ethnicity in your findings?
Yeah, I mean, yeah, that's a great point. I mean, I don't think we can ignore genetics. I think that is a large part of it. So I think it's important, but it's more to it than that. It's also behavioral, it's cultural, it's, this morning we were talking about, microbiomes even are probably different amongst different ethnic groups and different immigrant groups from different parts of the world. And then it's also the sort of bigger macro stuff like the social deprivation and the economic deprivation and so on. So I think it's all of the above. And so I don't know that I would necessarily want to say it isn't genetics, because I think genetics is part of it, but it's bigger than that. So I think I would argue that it's ethnicity is its own construct. Like, I don't think we can sort of use it as a proxy for something else, because it's its own thing. Yeah.
Whether in Canada there is a statistics such like from 1 year to another year, between 2 years, several first names are very popular. And you can use the first name to estimate age.
Yeah, that's a good question. I don't know about that. That would be very interesting. Like, there's that. I remember there was, when I was having my kids, there was that website of all that had like the most common names at each year, and you could see how the name sort of came and went in popularity. Yeah, that'd be interesting. Yes. Yeah, I don't know. That's a really good point. I don't know. Interesting. Yeah. Age we kind of have on all our databases, so we don't really need to. But it's a good point. Yeah.
Thank you for an excellent talk. I'm sure if others have questions they want to come up afterwards, they can. But fantastic.
Great. Thank you so much.